And now Jyoti Prakash sir will conclude the session with the final talk of the session, pharmacotherapy in CSR.
So I'll be taking on the last topic of the day. It's pharmacotherapy in central serous chorioretinopathy. Now, as controversial as this topic is, it has been taken up deliberately just for open discussion on the existence of these treatment modalities and the reality behind whether how effective they are and whether they should be used or not. Understanding CSCR, the other demographics and all, everybody has talked extensively about it. The various the mechanisms through which the pharmacotherapeutic agents work are, firstly, according to the various animal studies, it was found out that the mineralocorticoid receptor were the main receptors at the RPE cells, which actually led to the presence of the leakage of fluid from those cells, and the antagonists of these receptors tend to have a positive effect on reducing the fluid in these patients and improving the visual acuity subsequently. Eplerenone and spironolactone have been used extensively. According to some studies, it is said that both eplerenone and spironolactone are equally efficacious in managing CSCR fluid. The mechanism is that it blocks the mineralocorticoid receptors primarily located in the choroid and potentially reducing the choroidal vascular leakage, dilatation as well as the leakage. The efficacy, if you look at it, there was initially it was only anecdotal reports from different centers and different clinicians, but then came in 2020 or 21 early part when the Vichy trial was published, and it outright categorically disregarded the use of eplerenone as a modality for treatment, and it said that, and verbatim I just quote, that they said it was as good as a placebo. Then came in the role of beta blockers in CSCR treatment. Now, there are several studies in which people have used, again, metipranolol, nadolol, propranolol for reducing CSCR. Now, the reason why these tend to work is in a small subset of patients, as we all know from the historic teaching, that these patients are the type A personalities who are known to be prone to anxiety, and probably the effect of beta blockers on reducing the element of anxiety, that is how probably it helps in relieving the symptoms. That and all we do not know, because there has been no proper randomized control trial on this because of the anecdotal nature of the usage of these agents. Another very surprising detail which came up in the last 1 decade or so has been H. pylori eradication therapy. There have been some reports again in which people have actually shown that H. pylori eradication therapy using a metronidazole, clarithromycin, or along with amoxicillin for a period of 10 to 14 days actually tends to produce some level of reduction in serous subretinal fluid, although it cannot be quantified. Another important treatment, now rifampicin as a treatment option. Now I cannot vouch for it, but yes, I have used personally both eplerenone and rifampicin. Rifampicin, not now, at least 10 years ago, I was very rapidly using rifampicin, but then the mechanism of action is very simple. It is one of the most potent stimulators of what is known as the cytochrome P450 enzyme, which is the most potent metabolizing enzyme in the liver for most pharmacokinetic changes through which multiple drugs go. And since it stimulates that, it actually causes a rapid resolution of the cortisol levels in the body, for due to which they say the fluid accumulates. The doses which was advised were somewhere between 300 to 600 milligrams, but I deliberately made a point here to actually put it here just to caution everybody to use this, because in a country like India, where tuberculosis even today is a very important medical concern, and it is a second evolving epidemic following the presence of HIV, these drugs should not be used unless and until there is no other treatment option available, which actually is not the case. Other treatments are way more safer and effective, as Dr. Kiran had also highlighted in the past presentation. Rifampicin can be used but should never be on your first thought ever. Methotrexate, again, they say it is has been used. The mechanism, no idea how it works. It's said to be given at a dose of 7.5 milligrams weekly doses. It said in one study they showed around a 62% resolution, and the duration which was given for which was about 12 weeks. That is a huge amount of immunosuppression probably going around for a 3-month period. So other potential treatment options include aspirin, which has been there historically since the early 70s. It's been there, probably due to its effect on plasminogen activator inhibitory level activity. Carbonic anhydrase, as Dr. Kiran had already mentioned. Mifepristone, which is a glucocorticoid and progesterone receptor antagonist. And melatonin. Some of the pharma companies, you would have also heard, some of the people tend to push a particular molecule or a tablet which actually has some element of melatonin in certain indications. Now, how much it works, how really do they affect the patient, it really is a point of contention. So as far as the evidence goes, the strongest evidence is for mineralocorticoid receptor antagonists. The other one for rifampicin and methotrexate, the rest are limited and only insufficient evidences. So they are only mentioned here to just apprise you with the things which were used, and these are in no way the suggested treatment options. Another study which was recently done at Narayan Nethralaya by Ramesh Venkatesh, he did a real-world practice pattern of eplerenone, and this is in light of the after the publication of the Vichy trial, which actually kind of stopped many people, including me, from using eplerenone as a treatment modality in chronic CSR. It is not a treatment modality which is used in acute ones, but chronic CSR was the area where it was used. So he had studied around 241 specialists, 122 from India and 119 internationally, and they found out that out of the 241 participants, it was 62% used eplerenone, and the remaining 38% people used PDT. Now, the only problem is in India as of now, the Visudyne is not available, so PDT is not possible. Following which, the only other options which are available with us, one is eplerenone, the other is micropulse laser, and for an extrafoveal leak, it is the standard laser. So the patterns which were found in this was that 58% of the respondents used primarily for chronic CSCR. 49%, about half of them, gave a dose of 50 milligrams of eplerenone. 92% used it for 0 to 3 months, and 57% of the people used it when other treatments had failed. So even although Vichy trial says that this drug does not work, if you don't have anything at all, something like you don't have access to PDT, you don't have access to micropulse laser, you have a patient who has a chronic CSR with an added on acute on chronic pattern with a subfoveal leak, what do? You cannot say, I will not treat the patient. If you do not have anything at all, if the patient has a good renal parameter and no other medical contraindication to the use of eplerenone and no cardiac condition, you have to probably use anything at all. This probably is the only salvage point which can be utilized in such a situation. The regional differences in eplerenone use, as is always the case, Indian retina specialists tend to use eplerenone more frequently as compared to the rest of the world, and because, as the point has been reiterated more over and again, that the PDT is not available right now, and they start usually at 25 milligrams OD and graduate to 50 milligrams per day, and somehow the satisfaction rate with eplerenone use were good, whereas on the other side, in the internationally, the rest of the world, they were not so. All the other parameters were exactly the opposite of what data was received from India. So the Vichy trial results said that eplerenone is not superior to placebo. Global impact is that 69% of non-Indian specialists reported practice changes. They stopped using eplerenone altogether. 44% of Indian specialists still use these are the people who have actually answered in this questionnaire, and continued use is in a limited capacity only in select patients. This is a presentation actually where Dr. T.P. Vignesh was kind enough to send me 2 cases of his in which he had used chronic CSR patients in which he had used eplerenone. Now this is here is a 52-year-old male. If you see, he has a history of defective vision in the 6 months, although the vision mentioned here is 6/9, but the patient had a significant problem in near work. So if you when the patient underwent FFA, you can see a characteristic subfoveal location of the leak, and since PDT is not available, he was given the option of eplerenone for a period of 1 to 2 months, and surprisingly the patient was called, he had called exactly after 12 days, within which you can see there is a difference in the fluid. The fluid is gone and the vision is improved from 6/9 to 6/6. Although this may not be as dramatic, I do not say that it works as magically in all cases, but in this case, yes, definitely there was an improvement. Another case which you can see now, this unfortunately he could not send me the fundus photographs because he was traveling, so he sent me only the OCTs. Now this is a patient who has a defective vision for the past 2 years with a baseline visual acuity of 6/9 and a serous macular detachment with some intraretinal fluid also. An irregularity of the RP can be seen here. The patient was put on eplerenone for a period of 2 to 3 months, and actually you can see in the second month itself, the vision, although remained the same, the fluid has totally disappeared, and which remain completely off till the next 6 months of follow-up. Thank you.
Thank you.